A really major area of focus, at least in the last few weeks, have been the cardiac injury that we see in hospitalized patients with COVID-19. And I know that, Alex, you've been very busy, not just taking care of patients, but also collecting data on the different types of complications that patients experience when they have COVID-19 infection. Can you tell us a little bit about what you know for the cardiac injury? And I can speak to that a bit myself. And then also, there's a lot of thought about how blood clotting begins to predispose to some of these cardiac injuries. And maybe you could tell us about how COVID-19 affects clotting.
Yeah, Greg, and much like Vic, I really want to shout out my younger faculty members who've put in a huge amount of work on the front lines and has done the yeoman's work, right, of taking care of these patients.
Sure.
We've had a huge influx in our system at Northwell Health. Yeah, the numbers are what I call wartime numbers. You know, we have 100,000 patients, a few thousand patients, up to 3,000 at once in our health system, and about a third of those are intubated. So tremendous numbers, you know, with this. So we're actually gaining a good sense with respect to the cardiovascular and thromboembolic complications, you know, in this COVID population. And much like you all, we're starting a registry to better assess how and when these complications appear. The first thing that I can tell you, also looking at the literature in our own population, that the risk of thrombosis is about 3 to 6-fold higher than what we would expect. In the hospitalized population, specifically in the critically ill population that Vic was talking about. So this appears to be a highly thrombogenic disease. And what's interesting also, we really don't know in terms of the specifics of the coagulopathy, because indeed there are aspects of DIC, but it's not quite behaving like a consumptive coagulopathy. So yes, the D dimers are very elevated, but the platelet counts tend to be normal or near normal. The coagulation parameters, the PT-PTT tends to be normal as well. And fibrinogen levels also tend to kind of be normal or slightly elevated. So not a classic consumptive coagulopathic picture. However, as Vic points out, we've seen some of the early autopsy data, and patients are dying both from massive thrombotic events like MI, from things like saddle emboli in the lungs, from things like strokes, but also there's quite consistent pattern of micro emboli, specifically in the lungs. So one of the purported mechanisms is maybe this hyperinflammatory reaction, cytokine probably related. Again, an immense release of these inflammatory factors create a cytokine storm that folks have described. And patients get hypoxic much out of proportion as to what is seen, right, in the regular exams. And this kind of hypoxia is leading to a microvascular, hypoxemic process, and then maybe some right heart strain and other aspects. And there's also another school that talks about the oxygen stress, especially at the level of the red blood cell, that may be adding to this. So this could be multifactorial. So again, coagulopathy, yes. Again, fibrinogen levels, AT3 levels, factor VIII levels are all affected, but also evidence of severe hyperinflammatory response. And in terms of the incidence of disease, as you talked about, you can probably talk about the cardiac issues better than me, but we've seen both classic acute coronary syndromes, but also things like myocarditis in these patients. On the venous thromboembolic side, again, there's some studies that suggest a prevalence of anywhere from 20% without screening to as high as 40% using routine lower extremity screening, which is again about 3 to 6 times fold higher than what we would expect. So a very high prevalence of venous thromboembolic events in this population. And also what's unusual, apparently high prevalence of in situ pulmonary embolic events in the absence of lower extremity DVT. So some very interesting things about this disease.
Yeah, I think from the cardiovascular system standpoint, like you mentioned, it's not just the patients coming in with heart attacks. There are patients coming in with typically non-ST elevation myocardial infarction, but we are seeing some ST elevation myocardial infarction. Myocarditis actually seems to be relatively common in these patients, either through a direct effect on the cardiac myocytes or due to some other factor. Heart failure's been seen. There have been reports of new atrial fibrillation in patients that otherwise haven't had it, and other types of arrhythmias, sudden cardiac death, which a lot of us, and I think we're all three of us in the camp that we think a lot of these are probably massive PEs. But there's also been arrhythmic deaths, and from the coagulation point of view, a lot of catheter thrombosis. I don't know if you both have been seeing that, but that's been a big complaint at my center, patients clotting dialysis catheters or central lines.
You know, Greg, absolutely. At Northwell, I'm getting a lot of feedback from my renal colleagues. So renal replacement devices, dialysis, catheter-based therapies, ECMOs, all these are clotting through kind of standard anticoagulant regimens. So in our particular institution, we're really advocating for the use of alternate parenteral anticoagulant modalities, such as intravenous argatroban, for example, that we're using more and more, or potentially moving away from a PTT based to an anti-10A based regimen of monitoring on fractionated heparin.
And we've seen the same thing, Greg. We're seeing more venous thromboembolism than arterial. We've seen arterial. And arterial clots have been line related. We've had one leg amputation in a patient that got ECMO. We wouldn't see that very often. I mean, this probably wouldn't happen with just a sheath in place or a catheter in place. But with this very hypercoagulable scenario, I think we're seeing more problems like CRRT, central lines, et cetera.